Hello, so we're here today to do some more mental health training, and today we're going to talk about the Mental Health Act. My name's Emma Phillips, I'm one of the consultant liaison psychiatrists at Gloucestershire Hospitals, and I'm here with my colleague.
Hello, I'm Dr. Jessica Harris, and I'm one of the other consultant psychiatrists that works here at Gloucestershire Hospitals Trust.
So thinking about the Mental Health Act, that is something that people aren't often very familiar with in an acute hospital setting, and it's not something that is used very frequently there. But I think people should be very familiar with thinking about the idea of what legal framework they're using to treat their patient. And you can think about that in several ways. Obviously, most of the patients that we treat in the acute hospital have got the ability to make the decision to be there and to consent to their treatment. They have that capacity to make those decisions. But there are occasions where we treat people who aren't able to make those decisions themselves. And there are a couple of different legal frameworks that we think about in that scenario.
Yes. So people are really familiar with the Mental Capacity Act. That's the one where people are talking about doles and capacity. But there are times when that's not the best legal framework to use, and that's when you start to think about the Mental Health Act, which is far less commonly used in the acute settings. Most people who are here in our hospitals are here because they're physically unwell, and the Mental Health Act is designed to be a legal framework for the care of people where you're looking after their mental health or if they have a psychiatric illness. Mm-hmm. It's not a good piece of legislation to use in the acute trust. It wasn't designed for that. It was designed to be used in psychiatric settings, and that can mean it's complicated to use in the acute setting. And when people aren't familiar with using it, it can be difficult to get all the different bits of it right and to understand what that means for the care of your patient, because it is different than the sorts of things we think about using the Capacity Act.
Okay, so the Mental Health Act is a legal framework, so it's a piece of statute legislation. So that means the government have created the law and it's been through sort of Parliament and things. And we use it to treat mental illness. So are there kind of specific criteria about when you might use the Mental Health Act for mental illness?
Yes, and this is where it can be difficult for people to think about what they're doing with their legal framework, because in the same way that we're used to using the Capacity Act to stop someone leaving the hospital or to make decisions about their care, and you're depriving them of their liberty, and you have to have a safeguard around that, the Mental Health Act does the same thing in many ways. But instead of thinking about simply whether the patient can understand or communicate their decision, we're thinking about the risk. And we're also thinking about the disorder that we think the patient might have or that we know they have.
Yeah.
And so the criteria about how you assess whether to use the Mental Health Act is dependent on different criteria, the risk and the mental illness, rather than just whether the patient can make a decision for themselves or not.
Yeah, okay. And so I suppose there might be times where we have to use the Mental Health Act and the Mental Capacity Act. And it's quite tricky to figure those out, isn't it, in terms of what's the most appropriate
And I think
framework.
that's often a conversation we have with our acute trust colleagues. As one of the things that's very difficult to pull apart is that the Mental Health Act is for looking after someone's mental health. But there's limitations to that. And often if patients are medically unwell and they're in the hospital, it might be that you need to use two pieces of legislation to correctly look after them, because just the Capacity Act might not cover their mental health.
Yeah.
And equally, the Mental Health Act can't always cover all the treatment that a patient might need in hospital. So that's one of those areas where it is really complicated to think about what you should be doing. And that's often where we have conversations with people to make sure that they're using the right thing.
Yeah. So the Mental Health Act can really only be used to treat somebody's mental health and the physical consequences of their mental disorder. So if, say, they had, blood pressure problems that were completely separate to their mental health, we couldn't use the Mental Health Act for treating that, even if they were refusing the treatment.
Yeah, and that's one of the things that needs to have some thought put into it. What are you trying to do for your patient, and which of the legal frameworks suits that? So if you have a patient who's in hospital where you need to look after their mental health, say if a patient had a serious mental illness like schizophrenia and they were unwell, and we needed to have a legal framework to look after them properly, we would want to use the Mental Health Act to look after whatever care they needed for their schizophrenia. But if they were here because they had appendicitis at the same time, that is not linked to their mental health. And so we couldn't use that legal framework. The patient may also not have capacity to decide whether to have that surgery. And that's an example of where you might need to use two legal frameworks for a patient who can't agree
Yes.
to the necessary care.
I see. And as I said, so there are some rare circumstances where you could use the Mental Health Act to treat physical symptoms, and that's where the Mental Health Act, their mental health has direct consequences leading to the physical disorder. So, for instance, the most obvious thing is if somebody's taken an overdose, you could use the Mental Health Act to treat the consequences of that.
So we could use the Mental Health Act in that situation to give them fluids or treatment they need in the emergency department. You can also use the Mental Health Act if somebody has injured themselves and they needed to have sutures, for example.
Yeah.
And then it also includes treatment if someone has an eating disorder. It's the Mental Health Act that we use to give them food or vitamins or whatever they need, because the starvation is a consequence of the mental illness.
Yeah. Okay. Well, let's talk about some of the common parts of the Mental Health Act that you might actually come across in the hospital. I think probably the first one that we should think about is Section 5.2 of the Mental Health Act, isn't it?
Yes.
And that is sometimes referred to as a doctor's holding power. So can you talk a bit more about what that means?
So the Section 5.2, that is the part of the Mental Health Act that non-psychiatrists use. And that's the most interesting thing about that for us, is even though we deal with it a lot, that's not for us as psychiatrists. That's for other doctors in the hospital to use if they have concerns about a patient's mental health. And it's a holding section because that's the only thing it gives you the right to do. So if you're one of the doctors who's an F2 or above, has concerns about a patient and they think the patient shouldn't leave the hospital, they think that patient should be seen by psychiatry, they can use a Section 5.2, and that gives them 72 hours to keep the patient legally until they can be seen by a psychiatrist.
I see.
It doesn't mean that they can give them any treatment under that part of the law, and that is really important. All it can do is allow someone to legally keep a person here until they can have a psychiatric assessment.
Yeah. So the point of it is that for a Section 5.2, you have to believe that the person has some degree of mental disorder that might be affecting their behaviour, and that there's a risk attached to that.
And there's a risk.
And you think that they might need a further Mental Health Act section, but you can't decide about that because you're not a psychiatrist.
Yes.
So you're keeping them for 72 hours. You've got that length of time for an assessment to be organised.
Yes. So you don't have to diagnose, you don't have to manage, you just have to have those concerns, and the risk seems serious enough that you should do that to that person to insist that they stay until they're seen by a psychiatrist.
Yeah. I've certainly come across times where I think people think that maybe Section 5.2 you can use for treating a patient. So somebody's been put on a Section 5.2 and then they've received some treatment for their overdose when perhaps it's unclear whether they were consenting to that or not. But I think that's something that we need to be really clear about with the Mental Health Act, isn't it? Is that you can use the Section 5.2 to keep the person in hospital, but then you have to have a different legal framework for treating them unless it's an emergency.
So in an emergency, you can do things, especially if it's going to save the person's life. But in that situation, if you've got your patient and you're not a psychiatrist, they're on a 5.2, you might have to think about whether you need to act in their best interest. And doing a really thoughtful capacity assessment in that situation might mean that you can also use the Mental Capacity Act, because you haven't got the safeguards of a different, more effective mental health section at that point.
Yeah. So practicably in the hospital, if you were a doctor going about your business and you came across a scenario like this, there's several things that you need to do to be able to use a Section 5.2. I think the first thing is where you actually get the paperwork from, isn't it? Because it's a formal legal piece of paper. And the site office are very helpful in this regard, aren't they? They've generally got access to most of the Mental Health Act documentation, and they also have some oversight of the Mental Health Act. So if you're not sure what to do, I think the first thing to do is to contact the site office and see if you can get some help from them. There are paperwork, I think, available on the paediatric ward and AMU as well.
Yes, and if you can't find them for some reason, they are all available on the .gov website, but I think it's a good idea to go to the site office first, because if you've got a situation where you're trying to use a 5.2 section to keep a patient in the hospital, you might want to be bringing in more senior staff and the site managers anyway, because there's likely to be a situation they should be aware of.
So when we use a Section 5.2 in the psychiatric hospitals, we have quite a clear pathway about who's allowed to actually use the Section 5.2, because the law suggests that it should be the person who's in charge of that patient's care or their designated deputy. And so in the hospital in Wootton Lawn, there's a designated person who's a bleep holder who's able to use the Section 5.2s in the absence of the consultants. But if you're here in the hospital and it's day to day, then if there's actually a consultant around, they're the most appropriate person to be applying the Section 5.2 if they're available. And then I think otherwise, generally, we would suggest that it be the medical registrar. But you should be able to also try and get some advice and help from the mental health liaison team if you're worried or unsure about what to do. And even the clinicians who are non-doctors out of hours are familiar with the frameworks and how to go about doing it, aren't they?
Yes.
Yeah.
And one question we do get about who can use the 5.2 is whether nursing staff can use the Mental Health Act. And if you are a general nurse in the acute setting, then you can't use this piece of legislation, which is a bit different from the psychiatric setting. You also can't use a 5.2 or sign that legal document if you are a F1 doctor, because you're not a fully registered medical practitioner.
You have to be registered with the GMC, don't you? Yeah. The other bit that we haven't mentioned about Section 5.2 is the fact that it is limited to inpatients of the hospital. So patients have to already be admitted to the hospital before you can use the Section 5.2, which means that you're not able to use it in the emergency department.
Yes, and that's usually really frustrating because that's often the point where you might have the most agitated patients or the patients you most want to keep in the hospital. But yes, you can't use a 5.2, and that's because if you are using a Mental Health Act section, you're detaining the patient to the organisation. The emergency department counts as a public place, even if it's behind locked doors, and those patients are not inpatients, they're not admitted to the trust, and therefore the trust can't hold legal responsibility for holding them. So if you need to use a section of the Mental Health Act, you have to think about where your patient is. And get some advice from the mental health liaison team if you have a patient you think needs to be cared for under the Mental Health Act, but they're still in the ED.
So what if you've gone ahead and you've used this piece of paper, you're thinking about what you might actually do and what then happens. Hopefully you've spoken to the mental health liaison team and they've given you some advice anyway, but say for some unforeseen circumstances they're busy and they can't talk to you, you've now got this piece of paper. What you then need to do is to deliver the paper to the hospital managers. That's the sort of legal terminology around it. And the designated people are the site team in the hospital, aren't they? So you've got your piece of paper, you have to hand it to the site team and they have to accept it with a time and date. And that then detains the person legally to the hospital. But then what happens?
So we have had situations where people have been put on these sections and nobody has followed the process through. And that causes a really big difficulty because at the end of those 72 hours, that section ends and that person is free to leave, even if you still have the same concerns that you had in the first place. So the site office understand the importance of someone being on a 5.2 and they can help you arrange the next stage of the process, which is that patient needs to be seen by a psychiatrist. That's the point of putting them on the section, and they will be able to coordinate whether the patient also needs to have a full Mental Health Act assessment. And that's the next thing we're going to talk about, where the patient goes through a process where they have a specialist assessment by 2 doctors and someone called an AMP, and we work out whether they need to be moved from a holding section onto an assessment or a treating section of the Mental Health Act, depending on what the situation is.
So an AMP, the mysterious acronym, so it stands for Approved Mental Health Professional. And AMPs are a whole variety of different people, aren't they? Some of them, I think most of them are social workers, because historically, in the previous iteration of the Mental Health Act, it was an approved social worker was the person who coordinated Mental Health Act assessments. But I think in the most recent version of the Mental Health Act, it can be anyone with a registered mental health profession who can apply to do the training to be an AMP. So some of them are mental health nurses. And I think previously in the county we had one person who was an occupational therapist, a mental health occupational therapist.
And they've done the specialist training to become an AMP.
And then the specialist training is fairly detailed, I think, isn't it, over a couple of years, and they become very, very familiar with the whole of the Mental Health Act as a piece of legislation and what it means and the rights and responsibilities. So it's their job to organise and convene a Mental Health Act assessment if they think that's the right thing to do.
Yes.
And locally we have an AMP hub, so there's a sort of single point of access telephone number that you'd be able to get from the site team for clinicians to phone. So once your patient's been put under Section 5.2, or if you're calling for a Mental Health Act assessment without using a Section 5.2, you call the AMP hub and you refer them to have a Mental Health Act assessment.
Yes. So AMP will have a look at the information you've given them. So they will recognise if the patient's on a 5.2, they're going to need to think about the timings. And they will also take some information about why you have concerns about the patient. And they will very likely respond to that by organising a Mental Health Act assessment. And they do have this specialist role. It is their job to organise the assessment. And it's very important that they are the independent person that does that, away from psychiatrists. To do a mental health act assessment, you do need psychiatrists or Section 12 doctors, who are doctors who have done special training in the Mental Health Act, to come and contribute to that process. What can they expect if they see a Mental Health Act assessment taking place on the ward?
So for a formal Mental Health Act assessment where you're thinking about whether or not somebody is detained onto an assessment or a treating section, which we'll talk about in a minute, you need both the approved mental health professional, the AMP, who's like this independent person, as you say, and then you need 2 psychiatrists or 2 doctors. This has to be 2 registered doctors, and at least one of them needs to be a psychiatrist with this Section 12 approval. Section 12, it's called Section 12 because that's the section of the Mental Health Act legislation that it's described in, and that sort of describes the amount, the sort of training that you have to have, and then you have to have done a certain amount of bits and pieces and put yourself through an approval process, which is a national or sort of regional thing. So you've got 1 Section 12 approved doctor. Hopefully you've got 2, but the minimum of 1. And preferably some doctors who've met the patient before or know the patient if at all possible. So the AMP will have a think about who's the most appropriate doctors to do the Mental Health Act assessment.
And often if it's a patient who's in the acute setting, that might be one of us or other colleagues who are doctors.
Yes, and very occasionally it could be you that are asked by the AMP. If they're unable to find 2 Section 12 approved doctors, you might be the next most appropriate person. If you're a registered doctor, you can take part in Mental Health Act assessments if you know the patient and you've referred them. It's unusual. It's more usual for 2 Section 12 approved doctors to be available in Gloucestershire, but
legally that can happen.
Legally that can happen. And so then you get all 3 clinicians together, and you go to see the patient together. You have a discussion either with the patient or without the patient about the sort of risks and what you're seeing in the assessment. And you're making a decision as to whether there is mental disorder, first off, and then whether there are risks associated with that mean that the person couldn't be cared for in any other way apart from detaining them in hospital.
Okay.
Then, in terms of the other ways an assessment can take place, there are sometimes times where you might not have all the team together, aren't there?
Yes, if you can't get everybody together in that ideal situation where there's the 3 of you, sometimes the AMP, as part of their coordination of the process, might see the patient with just one of the doctors. They might be able to take the paperwork, it's all about the paperwork, from a doctor who's seen them a little earlier in the day, for example. But that's the important thing. You need to have the AMP and the 2 doctors giving the opinion that that person really does need to be detained for longer than that 72 hours.
I suppose the other important bit about that is that the doctors make recommendations, so they have a think about it and they decide whether or not they think there is sufficient evidence that the patient's detained. And then you can either make a recommendation jointly or with the other doctor, can't you? But you don't actually get to decide whether the patient's detained or not. The final decision lies with the AMP.
Yes.
So if you've made your recommendations, the AMP can make an application to detain the person to hospital. Obviously, if you don't make any recommendations, the AMP can't then detain them by themselves either. But essentially, you need all 3 of you to be in agreement.
To be in agreement.
Yeah.
And then at a practical level, that involves more paperwork.
Yes,
but,
paperwork.
For clinicians in the acute trust, they don't have to do anything with that paperwork. They don't need to sign anything or do anything. It's the AMP coordinating that assessment who then takes care of the paperwork to change the patient's status.
Yeah. And that the hospital does have to receive the patient under the Mental Health Act. So one of the site team or a designated senior nurse will have to accept the patient under the Mental Health Act to the hospital. But that's a little bit like the same thing that you do with the Section 5.2. So what are the different types of section that we ought to talk about?
So the one we actually use the most often in acute settings is Section 2 of the Mental Health Act. That's a section that means that you can hold the patient in the hospital And you can do that for up to 28 days. So the purpose of that assessment, of that section, is to do an assessment of what the patient is presenting with. Have they got a mental illness? What are the risks? What is the overall situation? You can give patients treatment. You don't just have to watch them or observe under a Section 2. You can give treatment as well if it's appropriate. But Section 2 for 28 days is the one that we see for our patients who are on the wards most commonly.
Yeah. And that's when, usually when it's a newish presentation, the patient's not well known to the teams. You believe there's some mental disorder, but you're not perhaps 100% sure what's going on.
And having that longer period of time rather than having to make a one-off decision at that is often very helpful, particularly because mental health presentations can be harder to diagnose, it can be more complicated. So having 28 days is helpful.
Yes, so it's time to observe and treat the patient as needed. Yeah.
Sometimes you do see patients where they're really well known. Or it's very clear that this is something we're all familiar with.
Yeah, they've been like
we
this
understand
before.
the patient.
They've been in hospital with the same thing before.
Yes. And in that case, they might, rather than going to a Section 2 for 28 days, almost skip that section and go on to a Section 3.
Yes.
Section 3s, they last for 6 months.
Or up to 6 months.
Or up to 6 months, because patients don't have to stay on section for the whole time. And this is a treatment section. So if somebody's on a Section 3, it means that there is solid agreement that we know what the mental health problem is and we have a plan about what care they need to receive and that they're not able to consent to it or agree to what's necessary.
Yeah. I suppose we didn't really think at the start, did we, about patients' capacity around the mental health, that you just said about them not agreeing. So that I think often, that the patient doesn't agree to what we're doing or doesn't believe that there's mental disorder. But there are times, aren't there, where the patient simply lacks capacity around their mental health. And that's perhaps a little more often for older patients with, say, dementia or other things, and we can use the Mental Health Act occasionally to treat them in mental health hospitals. And so, we would think then about their sort of capacity to consent to the treatment rather than whether or not they're really formally agreeing or disagreeing to it. Yeah.
And it can be a really nuanced decision, particularly people who've got a disorder like a dementia, an older person. They're so frequently cared for in the hospital and so frequently cared for under the Mental Capacity Act.
Yes.
It can be a really detailed discussion about what counts as psychiatric treatment and therefore should be done under the Mental Health Act.
Yeah.
And that's best done in a discussion with mental health liaison team.
Yes, absolutely. So the Section 2 is for 28 days, and that's the assessment and treatment. And the Section 3 is for up to 6 months. Well, I mean, the Section 2 is for up to 28 days as well, isn't it? So up to 6 months, and then that's for treatment when you think you know what the mental disorder is. Are there any other differences between them?
Patients have different rights, and that's a very important thing. So if you're looking after a ward and you have a detained patient, there are things that you may need to do as part of your responsibilities. And the mental health liaison team will support you in that, as will the site managers. But it might be that you will see that there is documents that are left for patients. They come in from the Mental Health Act office and they need to understand their rights. They need to be supported in understanding what it means for them to be detained if they've got the capacity to think about it. So there may be that you are asked to do different things to support that patient, particularly because patients have the right to appeal. They don't have to accept that they're detained. And you may be involved in that process, which I don't think we're going to talk about in great detail in
Perhaps
this teaching session.
No.
But patients do have rights and you are a part of the requirements to make sure that they're met.
So part of that is about them knowing what their rights are. And so sometimes that happens, doesn't it, by the Mental Health Act office, which is based at Wootton Lawn for Wootton Lawn and for the acute hospital. They will send paperwork to tell people about their rights. The AMP would usually also have told people about their rights, but people should be given their rights on a regular basis, shouldn't they? And I think that's slightly different for Section 2, which is quite frequent because it's a short period of time, and Section 3, which is longer, so less frequent. And the two main rights you picked up on there, weren't there, were the right to appeal, so that's to object to them to being detained under the Mental Health Act, and that leads to a variety of processes we can talk about very briefly, can't we? And then the second right is that they get an advocate, isn't it? So that is something that the hospital can follow through on, whereas the appeal is a bit more for us to try and sort out. anybody who's detained both under the Mental Capacity Act or under the Mental Health Act has the right to an independent advocate to try and support them around their care. And both of those come from an organisation called POWER, which has got an H in the middle.
POWER with a random H in the middle.
POWER. And if you're uncertain at all about that, I think the safeguarding office are able to give a bit more information about that and how you access those advocates. But if you've got a patient who's detained and they're asking about advocacy, then that's certainly something that you can support them with as a referral form or a telephone call to the POWER team.
Yeah. So one of the things I think we should mention is that patients, when they're in hospital and they are detained under the Mental Health Act, they can't just leave the hospital and they can't be discharged from the hospital if they are detained under the Mental Health Act. And it's worth mentioning that because people need to be aware that with that legal framework in place, there is a process to have to remove a section before a patient can leave the hospital, and that does have to happen.
It does, yes, absolutely. So the mental health liaison team consultants, and at the moment there are 3 of us, hopefully soon to be 4, will take it in turns to be what's called the responsible clinician for the patients who are detained under the Mental Health Act. So that's part of the law of being under the Mental Health Act, is that you have to have a responsible clinician, and they have to have had a degree of training in the Mental Health Act and that law about what happens in your care. And it's only the responsible clinician who's able to discharge the person from their section and allow discharge from hospital.
And that's different from perhaps the person you think might be responsible for their care on the ward. It won't be the physician or the surgeon who's leading on their care clinically in the hospital. This is a separate legal status, and it does have to be a psychiatrist.
It does, yeah. So it's one of us. So if you're unsure about that, then please get in contact with Mental Health Liaison team. Out of hours, it will be the on-call psychiatrist for Gloucestershire. So you get hold of them via switchboard if there were any specific issues around the Mental Health Act out of hours, which I think would be a very unusual situation, because hopefully the Mental Health Liaison team should have sorted out all of those bits and pieces during normal working hours, shouldn't we? So aside from that, the patients have other bits of the Mental Health Act that are relevant to them when they're in hospital. I'm thinking particularly leave from the hospital. So you said they're not allowed to be discharged, but they also have to remain within the hospital grounds, don't they?
They do. And one of the things we're asked is about whether patients can go off the ward if they're detained. So legally, they don't need to have special permission to go off the ward as long as they are on hospital grounds, and that includes outside, although we do appreciate conversations where people think about the risk and whether the patient should be able to go outside. If a patient's detained under the Mental Health Act and they are going to be leaving the hospital grounds, and in some cases where they're going to be transported between different hospitals, they might need a separate part of the legislation to be in place for them. There's something called Section 17 leave that we can use, which means that you go through a process of thought and risk assessment about whether a patient is safe to be away from the hospital they're detained to.
People might also come across Section 17 leave if there are patients from either Wootton Lawn or Charlton Lane or other psychiatric hospitals in Gloucester Royal or Cheltenham General. And those patients can sometimes be detained under the Mental Health Act to those mental health hospitals, but be on Section 17 leave for physical health treatment. So that's another time where you might see the Section 17 leave.
And we tend to do that when we think patients are going to be in the acute setting for a relatively short amount of time and are extremely likely to need to go back to the psychiatric setting.
Yes, exactly.
Usually we might think about it being, are they going to be here for less than 2 weeks? But it's always an individual assessment of the situation. There's not a set rule.
Occasionally, we might want to transfer a patient under the Mental Health Act from one hospital to another. That doesn't include, I don't think, between Gloucester Royal and Cheltenham General, because that's part of the same detaining authority. But say you wanted to transfer a patient who was under a Section 2 from Gloucester Royal up to Wootton Lawn, that's a different detaining authority, and so we would have to do some paperwork associated with that, and that's called a Section 19 piece of paper. So if you're moving a patient who's detained to another psychiatric hospital, which might be, for instance, a specialist eating disorder hospital somewhere else, then that piece of paperwork has to be completed, doesn't it? Otherwise, there's no right to convey them to the next hospital and no right for the hospital to admit them under the section.
Yes, and it's an important thing to remember if you are transferring someone, because that is how that legal responsibility passes to the receiving organisation. So you have to register that you're transferring the patient on your piece of paper, they have to countersign it, and then they're supposed to send a copy back to you, and that's what completes the process of moving the patient to a different organisation.
So there's those two bits of paper. The section 17 is leave, but they're still detained to the hospital they were originally detained to, and then the section 19 is transferring them to a different place. Yeah. So there's a couple of other bits of the Mental Health Act that are probably helpful to think about that you might come across in the acute trust, and these are both police powers, called Section 135 and Section 136. Section 136 is the most common one, isn't it? And that's where the police find somebody in a public place where they believe it might be some mental illness, and they need to convey somebody to a place of safety for further assessment. So Section 136 allows them to do that. So they're able to use that section of the Mental Health Act, a police power, and they have to bring them to a health-based place of safety. In Gloucestershire, we've got something called a 136 suite, haven't we? So if the police don't think that there's any physical problems for the person, they'll take them straight to that mental health place of safety.
Yeah.
But occasionally they might be worried about their physical health, and the person might end up in the emergency department under Section 136. What happens then?
So two things can happen. If the patient is under the care of the police force, they're on the 136, so that's the legal framework to move the patient around, and they think they might need to be assessed. Perhaps they've had a head injury, perhaps they're worried they've taken some medication. They can bring them to the emergency department and still have the legal responsibility for the patient under that law.
Yes.
It might be that the patient just needs assessment or a short amount of intervention, usually within the emergency department. And the police can stay with them, can keep them under the 136, and then when that intervention is finished, they will return them to the most appropriate setting, which is the 136 suite, which is just round the corner from Gloucester Hospital at Wootton Lawn. If a patient is not going to be able to go to the 136 suite and they're perhaps going to have to stay in the hospital for a bit longer, something needs to change in terms of their legal status, because you only have 24 hours that a patient can be on a Section 136. Yes. That's 24 hours for the police to hold that patient and either get them to have an assessment to see if they need to still be under the Mental Health Act, but a different section, or for the 136 to come off. And that's often where we have trouble.
Yes. So I think it's worth thinking about the 136, particularly if you're an emergency department clinician, isn't it? Is that as to whether or not the police remain with the patient, or whether the hospital accepts the 136 and then is responsible for the care of the patient themselves.
And that's a difficult decision to make. And again, it's one that's based in risk. If you have a patient who is very agitated, or there's risk to other people, it might be that you would want the police to stay, or you need to think about whether the security team can fulfil that role in managing that risk. So it's always a discussion between the police force and a senior clinician within the emergency department about whether the police need to stay with that person.
Yes.
And part of that is thinking about whether they're going to be moved quite promptly out of the department and need to go to the 136 suite. So a bit of common sense has to apply, although it can be difficult to predict.
It's very tricky to know sometimes, isn't it, I think. I think there's a thing nationally as well called Right Care, Right Person, where the police are increasingly struggling with the number of mental health presentations in the community, aren't there? And very keen to try and draw in more appropriate services to support those patients. So I think increasingly the police are not keen to remain with people if the main problem is that it's mental disorder or mental illness, and trying to get them the appropriate care, which is understandable.
So one of the best things that we can all do in a situation where the police have brought someone to the emergency department is to try and work out as quickly as possible what their care needs are. The police are very good. They will take them to the 136 suite and wait if it's going to be something that we can already identify and is going to be relatively quick to deliver. They don't want to stay for 24 hours looking after a patient whilst we're waiting for things to happen. And particularly if the patient is very settled, it might be appropriate for us to say, well, we'll take responsibility for that patient. And before that 24 hours is up, we need to make a decision about what's going to happen.
Yes. Now, with the Section 5.2 that we talked about earlier, that is sort of a similar sort of holding power, but a doctor's holding power, and that holds the patient for up to 72 hours. And with the Section 5.2, the AMPs might make a decision that a psychiatrist could discharge the section without them if it seems appropriate. But that can't happen with a 136, you need the presence of an AMP and a doctor, I think, to make that decision around the discharging of the section.
Yeah. It would always require mental health clinicians to be involved in the 136 being removed.
Yes.
It's not good practice to ever let a section of the Mental Health Act lapse.
Yes.
It's never good practice just to let the time run out and say, OK, they're an informal member of the public again. So if you have somebody on a 136, having those conversations as soon as possible because the clock is ticking will always make it more simple.
It's probably the first thing that somebody might need to do if they came across a patient under 136 in the emergency department is to contact the AMP hub so that everybody knows where the patient is and that assessment that needs to happen can be sorted out, isn't it?
Yes, and the 136s always seem to go on in the middle of the night, so they're always going to run out in the middle of the night, so you may not even have the full 24 hours to get organised.
To get stuff done, So in terms of other practicalities, I think what to do with the paperwork is the big thing. So we've talked about the site office, haven't we? And we've talked about actually then making sure that once you've done the bits of paperwork that the AMP hub are actually aware of the patient and those processes can be followed. Are there other kind of practical bits of advice that you think people ought to have?
So don't lose the pieces of paper. The whole use of the Mental Health Act really relies on these statutory documents being completed properly, timed and dated. Detail really matters or you can quickly invalidate them, and they do go missing when they're left with patient notes, particularly in really busy clinical areas. So you've got to keep the paperwork safe until somebody can take responsibility for it. You can make copies of the paperwork and you can upload them to the patient's electronic records, and that's always a very sensible thing to do. You can also make copies of the original paperwork and put them in the patient's paper notes if they're on the ward, and there is actually a section in the back of everyone's paper notes where you can keep legal documents. So there is the appropriate place to find them. But the original documents often have to go off because they are special and they have to go to the Mental Health Act office. How do they get there?
So I think that the best way of them getting there is somebody actually walking over to Wootton Lawn and delivering them to Wootton Lawn reception usually.
So they cannot get lost.
They can't get lost that way. I think occasionally they do go in internal mail, but on the whole, we prefer that doesn't happen, do we? And if you've had a full Mental Health Act assessment with an AMP, usually the AMP would take charge of delivering that paperwork, and that's absolutely fine. They're usually fully aware of what they need to do with it. The Section 5.2s are more difficult though, so they should go to the site office, and then the site office should have an understanding of what to do with them, which is to deliver them to the Mental Health Act administrators up at Wootton Lawn, so that we can record. The other important bit to remember is that this is the document that you're using to legally detain somebody, isn't it? So it has to be completed completely correctly.
Yes.
And everything needs to be sort of firmly add up. You can't put the wrong date of birth or something on, because otherwise your patient could be illegally detained.
Yes. And I think it's amazing how often, despite quite simple looking paperwork like a Section 5.2 really doesn't require much information being put on there, but the number of times that it might not be dated or the time hasn't been put on there, with the really short sections of the mental health at the time that this process starts and the clock starts ticking matters. And if you don't put those things on, or you don't very carefully get the patient's details right, the form is invalidated, and then you may be practicing unlawfully. So this filling in of the paperwork, even in the middle of an emergency situation, it really matters that attention is paid, and it's worth getting somebody, say the site manager who might be coming to check that, check that through and have second pair of eyes on it, because it will avoid having to justify your practice later on if there has been a problem with the paperwork.
So I think finally we did say that we would talk a little bit about, we talked about how important rights were, but we said we would talk a bit about what the right to appeal looked like for a patient, and that is a situation that would happen fairly rarely in the acute hospital, but occasionally the ward teams are called on to do paperwork around this, so it is worth knowing about, isn't it? Patients have the right to appeal to two separate bodies, don't they? One's called the hospital managers, and this isn't actually the hospital managers, it's people who the hospital managers have designated or delegated those duties to, usually with experience of the Mental Health Act or mental health law, so sometimes solicitors or lay people with experience like previous mental health professionals. and then they will scrutinise all of the, what's going on for the patient and make a decision about whether the detention is lawful or not.
And if a patient wants to appeal to the hospital managers, they just have to put it in writing. And then this process starts where those designated people with that expertise have to respond to the patient or their relative, if their relative has written to them saying, my mum shouldn't have been detained under the Mental Health Act in your organisation. But it's really quite uncommon for people to use that as a way of objecting to being detained under the Mental Health Act. It's much more likely that they'll use something called a Mental Health Act tribunal. And we have had those take place in the acute trust.
Yeah. And so a tribunal is actually, a proper mini court that gets convened, isn't it? So it's a first tier tribunal, it's called, and because it's a mini court, there is a judge, and the patient can have a solicitor, and if it wanted, the trust could also appoint a solicitor, although that's fairly rare because they're not designed particularly to be adversarial. And then the other people that are on the mental health tribunal panel, apart from the judge, are an independent doctor with experience of the Mental Health Act, who also has the right to examine the patient, and a layperson who is often previously a patient or again somebody with experience of use of the Mental Health Act, like a social worker or somebody like that. So those three people are the panel. And a bit like with a managers' meeting, the hospital and the team who are looking after the patient will have to present evidence as to why they think the patient still needs to be detained. So there's three different bits of that, aren't there, in terms of the evidence that you have to provide. There's the doctor's evidence, so usually the responsible clinician. That would be one of us.
That would usually be us.
Yep. And then there's a nursing report, which is the bit that is important to Gloucester Royal because that would have to come from the ward who is looking after the patient. And then there's usually a social circumstances report from a social worker as well.
So if you're looking after a patient who is appealing to a tribunal, it can be quite a daunting process, particularly when you'll be given some guidance about how to manage a tribunal, and there is a lot of things you have to get organised in practice, as well as the documents that you'll need to create. When this judge and these official people come, it's a very serious process. But if you have to write a nursing report and you haven't done one of those for a mental health tribunal, you will be supported by the mental health team because we know what to write and there is a lot of guidance. The main thing is to talk about it early and work out who's going to be doing it because often you don't have very long before this very big event is going to take place, and it is a legal requirement. It's not something that we can elect not to do once that process is initiated.
So for a Section 2, the person, if they want a tribunal, they have to appeal in the first 14 days and then you've got a very short period of time where that can take place, can't it? So usually I think the most appropriate person to write a report is one of the senior nurses on the ward, but they can also have input from, say, if the patient's got registered mental health nurses looking after them, they can use bits of information that they're providing too.
And once you've done one and it's familiar, you realise that the information that you have to provide as someone who works in the acute trust is things you know about the patient. You're not being expected to provide specialist commentary on a patient's mental state. It's all about what level of care and support are they needing on the ward. It's familiar. It's familiar information.
Yeah. So that's a tribunal. Pretty unlucky if you get involved in one, but there is lots of help from the mental health liaison team. So if you find yourself in that scenario, I think the main thing to do is to come and ask for that help and support. And there are nurses in the hospital who have had to do that and would be able to help as well. Yeah. Anything else that we need to talk about, do you think?
I think the only other thing left to talk about is emergencies and having to think about a lot of this very quickly.
Yeah.
All of these things that requiring specialist input, specialist paperwork, specialist process. How are you supposed to manage that in an emergency? Does that mean that you can't use the Mental Health Act in an emergency?
Well, it's difficult, isn't it? Because you do have to get these people together to have an assessment. But I suppose emergency in the sort of general hospital sense usually means within the next hour or so, and that can sometimes be tricky for the Mental Health Act, can't it? But urgent, the Mental Health Act can be, for sure, in terms of things happening within the next few hours. And the AMP Hub are there all the time. There's always an approved mental health professional on call. Mental health Act assessments can happen overnight. So things can happen in a relatively timely way if you need them to.
If we need them to. What about if someone's detained and the emergency is that the patient has left the hospital and everyone's very worried about the situation?
So, you know, they're legally bound to stay in the hospital, aren't they? You know, in the same way that somebody who's in prison is legally bound to stay in prison. You know, it's that sort of level of legal framework around them. So the thing to do in that circumstance would be to call the police and explain that the person has gone missing, and that they're detained under the Mental Health Act and they need to be returned to the hospital. Obviously, at the same time as that, you could start calling the patient or calling their relatives, so that, you know, if they actually haven't left the hospital, you haven't called the police needlessly. So there's sort of practical steps around that. But if they genuinely have left the area, then that's the process there. Yeah.
Sometimes if patients have managed to leave a ward, security can be really helpful, particularly if there's CCTV. You may find that the patient hasn't actually left the hospital grounds.
Yeah.
And it's also probably going to be very helpful to contact the mental health liaison team, particularly if that happens out of hours, so that we can contribute to thinking about what risk the patient might pose, and contribute to that conversation with the police about the urgency with which the patient needs to come back to the hospital.
Yeah. And then I suppose the other bits of advice out of hours, you know, if it's advice about the patient's care under the Mental Health Act, then you know, there should always be a psychiatrist available for the care of that person, whether that's our team during the day or the on-call psychiatrist out of hours who remains their responsible clinician, as we were saying. Yeah.
And most patients who have been detained will be looked after in the hospital under the enhanced care pathway.
Yes.
That also gives some information about how patients should be looked after on the ward. And if something like that has happened, you might need to redo the risk assessment on there. It might upgrade their risk and change what needs to happen when they return to the hospital.
Absolutely, yeah. So they might need more enhanced care or, you know, changes in their care plan, mightn't they? So two policies really, aren't there, that are worth looking at from this perspective, the enhanced care one, and that there is a policy obviously around the Mental Health Act that has got all of those flow sheets in about how you approach the site team and how you apply Section 5.2 and things like that.
Yes, so the practical details are there, and also we very much welcome those conversations where you're not sure which legal framework is the best one to use. Even if it doesn't turn out to be the Mental Health Act, we're very happy to have discussions with people to make sure that we're providing the right care for the patients.
Yeah, so give us a call.